Now, let me then focus on what we define as periodontal surgery. Of course, periodontal surgery is a technique that we use to treat subjects affected by periodontitis. So as I said, it's a technique to solve a case, but we also take advantage of this technique in subjects with not affected by periodontitis. It could be either when we want to change apically the tissue or we want to move coronally the tissue. You see, the first areas is crucial to work on subject affected by periodontitis. The second one is crucial for perioprosthesis and Facebook, of course. Now, the criteria here are completely different. On the first hand, we attempt a pocket closure, whereas here we attempt a pocket eradication. The approach might seem philosophical, but is actually very crucial when planning the type of surgery in your, for example, treatment plan. One of the main problems, in fact, that we have in doing surgery is the understanding of the periodontal wound. When you have the wound in mind from a biological standpoint, then you know how to do your surgery. And let's face it, the periodontal wound is one of the most complex wounds on the planet, because, to be honest, you have an area which is highly vascularized, that will, of course, provide a stability to your blood clot. You have an area that is mineralized and vascularized that can also support your blood clot, which is the bone. But then in the middle of the wound, you have a sort of a layer of marble, these areas of the root surface, which is often avascularized. And really the main problem that we have in terms of healing, that blood clot is struggling to adhere to this part, to the root surface. Therefore, if you keep it in mind, you understand that the higher is the percentage of root surface in the wound, the most complex is the healing, and therefore the lower is the clinical healing. And so basically what is happening when we suture and when the healing starts, there are four basic principles that we need to address in terms of healing, thus when we do our surgery. First of all, as we know, if you later on you will undress and you look yourself naked at the window, sorry, hopefully not, don't do it at the window, do it in front of the mirror. If you do it in the mirror, whatever you will watch is epithelium. Whatever you can see, whatever you can put your eyes on, it's epithelium. We are covered by epithelium, and thank God, because epithelium allows to divide layers and strata of tissues. So every time that we finish a surgery and we have something that goes in and out, which is the root surface or the tooth, epithelium will rush into that. Plus, secondly, everything can heal if the blood clot is stable, and that's why we put a cast when somebody breaks one of the bone. And for the friends that are following me, they know that I'm very prone to accidents, so I know this story very much. But the main problem, as I said, that the root surface is really not conducive for a proper blood clot stability. This is why a suprabony defect or a craters heal less than an infrabony, because you have two root surfaces that are in the wound, and let alone a forcation where you have three, because you have the two roots plus the vault. So really, the higher the amount of root surface in the wound, the lower the clinical healing. Plus, always bear in mind that the weakest link of the entire wound, which is the root surface, it's also the one that is often contaminated, and contamination of the wound is the one that actually may impair the clinical healing. And finally, the complexity of the disease, the sequela of periodontitis, can alter the anatomy to the point that if you don't maintain space provision during the healing, you will end up with repair and not with regeneration. So these are the points that were highlighted by a wonderful paper of Sandro Cortellini and Maurizio Tonetti, that basically the point of a surgery is really to create space between the flap and the root surface to try to maintain a blood clot stability and to protect with soft tissue the areas to avoid bacterial contamination. The first two can achieve with the material, the second two can be achieved with your surgical flap, with your techniques. So when it comes to understanding the defect, because now we lose the patient, we stop thinking about the patient, let's think about the defect. I'm sorry, I've been asked to do something that I'm not capable to do. And let me see if I manage. They've been asking me to do, let me try. I hope that I managed to do it. Please send me a text, all my friends there, to know if everything is fine. So, okay, very good. Thank you. So we have a vertical defect infrabony then that can be divided in intrabony and craters according to the number of teeth. We have defects in the root, and then we have horizontal defect. Now, these are the classical definition of periodontal defects. And what we have tried to do in the last few years with our group is to try to understand the performance of surgery in each type of defect, because we come from a very important legacy and inheritance, which are the classical studies from the 70s and the 80s, where usually a patient was treated by multiple treatment, possibly every quadrant was treated with either surgery or not, and then followed up throughout time. However, those studies were designed to treat areas that show different type of defect. It could be suprabony, infrabony, furcation, and so forth. That's why we wanted to understand the exact healing according to the type of defect in order to assess what is the performance of the surgery. But there are also other defects, which are the apically involved defect, the dehiscence, or suprabony in craters, and even the furcation with infrabony. So periodontal defects are actually pretty various and pretty mixed, and it's important that we rely on something. So if I have an infrabony defect and I open, clean, and close, what is the type of healing that I should expect? I think that we tried to align this a few years ago, and it's very clear that on average, I should aim at the 3 millimeters of pocket reduction after debridement. However, what it also came clear that the result was strongly influenced by the type of flap. So the more conservative to the papilla you wear, the more clinical attachment gain you get. So to give an example, this is a patient, Mario, 34 years old. He was part of a trial that was just recently published in which we treated patients with or without amelogenins to try to assess systemic effect of the surgery. And the poor guy was randomized to non-surgical treatment. And when I say poor guy, it's because you can see the defect, which is pretty steep. It's 15 millimeters of attachment loss. And we treat him according to the principle of minimally invasive. Therefore, the papilla between 2.2 and 2.3 hasn't been raised and hasn't been detached by the attachment most probably of the 2.2. And you see there is just decontamination of the wound and suturing. No material, nothing has been placed. And this is the baseline. This is 1 year afterwards with basically nearly 6 millimeters of attachment gain. And you can see the healing. Most probably nowadays, I would have just changed a little bit. I think that I would have added also maybe a little bit of subepithelial connective tissue graft under the wound. That is a suggestion from Leonardo Trombelli, an important trial that showed that this increased stability. So the surgical flap has a tremendous influence on the healing. But what actually also has an impact on the healing is the type of material that we place. And look, in intrabony defect, we know the potentiality of GTR, amelogenins, or mixed technique when we use both amelogenins and bone grafting with Xenogen, for example, and we see before and after. So with these three techniques, we know that we have always an added value compared to opening, cleaning, and close, which is more or less of the same entity, as we in fact stressed in the last workshop from the EFP. The decision process, really, I think, when understanding a surgery is first of all to select the patient that have to have the plaque under control, inflammation under control, and most probably the smoking, then assess the defect and the papilla, and on that base choosing the flap that possibly should be as minimally invasive that you can, because that increases the wound chances to have a proper healing, and therefore choosing the material according to the defect supportiveness. So let's now apply this concept of the flap and the material to try to bring them in defects that are complex, like the apically involved defect. Basically, you see this defect that was sent to me with an hopeless prognosis for extraction, and because I'm a bit stubborn, the patient was treated in this case with grafting, with Xenogen, and covered with the collagen membrane. The reason for choosing the Xenogen is because if I wouldn't have done it, in this case, the flap would have collapsed into the wound. Therefore, I would have not achieved the famous space provision. At the same time, you can see that despite the amount of the flap, we still not touch this papilla. So we leave the papilla in place. So we apply all materials, then we suture, and that's the healing at 6 months, 1 year, 3 years, and then 5 years. You see, this is fundamental. The point of periodontology is to change prognosis of teeth that are affected. But it's not about the material, it's really about the compression from a biological standpoint. Look at this case, we have 14 millimeters of attachment loss. We see the defect is moving or circular around the tooth. In this case, you see once again, the papilla is left in place. We go and debride the defect, but because there is this bridge of bone here, the flap will not collapse in the wound, and therefore allow myself to apply some amelogenins. And this is the healing after 1 year, before and after. And what is important is the healing after 3 years that show that the pocket is closed. This is absolutely important. Always remember, the x-rays is for the show. What is important is that when you press the probe doesn't go through. That's when you know that things are done. And this is something that it was recently showed by the group of Sandro Cortellini and Maurizio Tonetti, where basically they've indicated that in apically involved and deeply compromised teeth, up to 10 years, they have the same survival of the one that have been replaced with prosthodontics, but most importantly, despite an initial higher cost, in the long run, would cost you less to keep your own teeth. Therefore, I think it is crucial that we'll do everything to maintain teeth. To be honest with you, I have a vision, I have a dream. I mean, in 2020, any periodontist should try to keep any teeth in the dentition. Then when thing goes wrong, after many attempts, I might start to think whether to replace it or not with an implants. But we'll get there. I'm sure that we'll get there. Anyway, another important defect, the essence. You see, the problem with the essence, as you can understand in 1 second, is the space provision of the defect itself. If I now would close this defect, the flap would collapse on the wound. Now, in my good old times, when actually this is my thesis of my specialty in perio, we did a very long study with up to 2 years follow-up of regenerative tissue in the essence type of defect, so this kind of defects. And we found out that you can achieve regeneration, and regeneration would mature up to 2 years due to the function, in fact. But what is important and crucial for regeneration is the space provision. So if you, in a defect like this one, what is important is to maintain space. Therefore, in the essence, I would apply some Xenogen, and then in this case covered by a collagen membrane, and this is the healing. This is actually the healing at 2 years with the pocket closed, and I also have the 4 years. There is maybe a slight remodeling of the soft tissues, but you can see it's still very much closed over there. So let me now move to defects that are involving 2 teeth, because so far we went, I mean, as much as we have an apically involvement of an intrabony defect, I would say that an intrabony defect from a biological standpoint has everything to heal. It's the amount of root surface is actually just a component of the wound itself. But when you have a suprabony defect, the majority of the blood clot would have to rest on a plate of bone and just try to connect them to different root surfaces. Suprabony teeth are very challenging because these are the horizontal defect. In fact, these are the majority of the defect. And I love these papers of these Indian colleagues that define the horizontal defect as the periodontal orphan, based on the fact that the majority of the literature is on vertical, but the majority of the defect are in fact horizontal. And what happens if I open, clean, and close a supraalveolar defect? Like in this case, we just use a papilla preservation flap, and then we clean and close. You see, before and after, we started with 6 millimeters. Now we have our pockets that are closed. What is the healing that we should expect in this situation? Basically, we know from this data from our group that you should expect really a pocket reduction that is surely inferior by the one that you would achieve in an infrabony component. What it may change, though, is the application, once again, of papilla preservation flaps, even in suprabony component, that is associated with higher healing, and surely a higher healing is achieved when enamel matrix derivatives are also applied. When we assess this from an histological standpoint, keep it in mind that now we move to some type of defects where the literature becomes extremely scarce, even from a wound healing standpoint, but surely from a clinical one. It might appear that with amelogenins, you might not achieve more cementum, like new cementum, new attachment, but the density of the soft tissue component, the supraalveolar component, is increasing. In fact, there is on average 1.2 millimeters of more attachment compared to just opening, clean, and close. So when we have this defect, this is a very challenging defect from Sara. I was about to say Sera, but in Italian it's Sara. Sara is a lovely capoeira dancer, and she showed after re-examination these residual pockets in the central area. And basically this is treated with the papilla preservation flap. And you see how challenging is this defect. Basically, we have just root surface. We have just a plate of bone, and we ask the blood clot to stay on top of it. From a biological standpoint, it's really challenging. So we apply some amelogenins, and here we suture it, and this is the healing. Look now, the healing I think is peculiar. This is 6 months after the surgery, then 1 year, then 2 years. And you see the creeping attachment, the papilla that is reforming. But despite there is an increase of soft tissue, you can see in 1 year the pockets are closed, and this is actually just a few weeks ago, which should be now approximately 3 years and a half with the area closed. Always remember that if you check the x-rays, you will not see any difference. We know this from the animal studies. That's why probing is important. And then let's apply this to craters. When it comes to craters, we have a defect that deserves to be highlighted a little bit. You know, technically and classically, we've been taught to treat a defect like this most of the times by removing this portion of bone and creating a sort of ramp. So by ramping palatally, we kind of remove the pockets. This is very much a pocket eradication. Therefore, the aim of the surgery is very different from the pocket closure that we talked before. This is a treatment that is absolutely effective in a treatment when you remove bit of tissues in order to achieve your final outcome, which is a very shallow pocket. In order not to compromise aesthetics, most of the times, as I said, the ramping is done on the palatal component so that there is no aesthetical impairment on the buccal side, the visual side. Now, once again, and I know that is not liked by many friends, I have to confess that despite I think that resective surgery is the most complex surgery in periodontology, I do believe that resective surgery is a surgery that one should do if he wants to become good in doing periodontal surgery. But I fail to see a space for periodontal resective surgery on natural teeth. Different story when we are talking about perioprosthesis, different story when we are talking about crown lengthening, restoration. In that case, you want to be resective because you want to have a clear prediction on where the soft tissue would go. So you would most probably accept to be, to maybe exaggerate, to over-treat in a way a side in order to gain in terms of predictability. But when it comes to natural teeth, I have to confess to you, in 2020, makes me cringe the idea that I have to remove some tissues in order to treat a chronic one. The problem is that I do remember the lecture that I received in 2001 in my first year of perio specialty. I was 12 back then, just in case you might wonder. But I remember the sentence was the following by a very famous periodontal surgeon. You can regenerate intrabony defect, but you cannot regenerate infrabony, basically craters. So what is interesting about craters that are really like a suprabony component with some lingual or palatal walls, or even the two of them, that are most probably can also be of unequal height. Therefore, it's a complex defect, yet that provides you some areas in which you might rest something. So based on the concept that basically we had from the suprabony defect, we started more and more to work on the technique to use both the application of amelogenin as it would be an horizontal defect, and then some grafting, and then amelogen again. Let me move, otherwise we'll never make it as usual. And basically the point is the following. You see here we have classical craters, quite a significant attachment loss. You can see there is this bowl-shaped, this cup-shaped of the defect. So what we do, we treat the root surface as it would be a suprabony defect, so we apply the amelogens. But we take advantage of the bowl, so the cup shape, these containment of the defect, to apply something to avoid possibly flap collapse in the wound. And this is very much the technique. Therefore, it's a sort of a bilayer technique, if you want. 3-layer is a sandwich technique, but this is to try to take advantage of the wound. And this is before the surgery, and this is just after 1 year at the re-instrumentation. And I think what is important is that the stability of the soft tissues that is very much different from what you would expect from a resective approach. Although, of course, once again, this is a story that I would apply on natural teeth. And another defect a bit deeper, and you can see we have 10 millimeters of attachment loss at 1.2, 13 on 1.1. From the X-rays, we see this variation of radio transparency, and then once again we apply the surgery. But as I always have stressed, look, we always try to maintain soft tissue every time that we can in the papilla. So we try to apply the minimally invasive concept, and we try to apply with our material the highest support to the wound. Therefore, once again, we will go for, let me remove this horrible thing. Then we'll apply our enamel matrix derivatives, then our xenogen in the wound, and then our suture, very simple, and this is before and afterwards. This is 8 months after the surgery. And you can see, once again, the pockets closed. I highlight the probing all the time because, as I said before, in suprabony component and in infrabony component, you will not see great changes from an X-ray standpoint. What is important then that you will look at the probing per se. In fact, you see here that before and after, you would barely see some changes. Now, let me move before discussion, and I was so concerned of being so long that I actually have to realize that I spoke pretty fast. Better so, we'll have plenty of time for the discussion. But you see, forcation are the trickiest bit ever in periodontology. As I said before, you have to bear in mind how the wound works. So on one end, patient cannot clean back there. You cannot brush, you cannot clean either very well. At the same time, every time that I have a wound, what you have, it's a blood clot that would rest here and surrounded by 3 root walls, which are the vault and the 2 root surfaces. So really, from a biological standpoint, what you're asking, a forcation, is very complex because you are asking a blood clot to just rest on a plate of bone and at the same time be capable to colonize and attach some root surfaces. Root surfaces then most probably are even more polluted, contaminated, because as we know by the study from Svanstrom and Wenstrom, the anatomy of the vault is extremely irregular, with lots of pits, bridges, depressions. So it's very likely that when you have plaque accumulation in those areas, it's extremely complex to debride. That's why, as much as I'm really not a fan of burrs for instrumentation for root surface, but I just use mainly manual instrumentation, especially nowadays. But I would think that in the vault of the forcation, we need to do something more. Now, forcation are indeed very much affected the majority of the time, and we know that within time, in subjects with periodontitis, is forcation the ones that are affected the most. And there is a sort of a progression. You will see within the years that forcation defects are more and more present. I referred before to the paper from Svanstrom and Wenstrom that clearly showed that the anatomy is so complex that it's very easy, in fact, to have bacterial accumulation in the vault. This is something that we know from non-surgical treatment, the classical study, I remember for all the periodontists there and all the residents, they surely remember their 6.5 follow-up, I think from Bruce Fieldstrom, if I remember correctly, because I think it's a unique paper, the 6.5 follow-up. But really, the healing of non-surgical treated bifurcation is very complex. And there is a wonderful data from still Cristiano Tommasi and Jan Benstrom showing that the factors that would influence the healing of treatment in bifurcation from a surgical standpoint are the fact that the patient is smoking or not, whether there is plaque or not. So we have a patient factors, we have side factors, but also the vertical component of the bifurcation is also crucial. So if I have a bifurcation with a deep vertical component, there is a lower chance of healing. And therefore, when we see and look at this data, it's very clear that the capability to close, especially, to clean and debride effectively the bifurcation area is very much depending on a surgical approach, whereas a non-surgical treatment is destined to fail. Well, destined to fail is a sentence that I wouldn't like to use. Let's say that might not achieve bifurcation closure or bifurcation conversion, but surely if it's well conducted, there surely will be some important changes in the bleeding of the area and also some reduction of the pockets. When it comes to access flap, then what is the impact of opening and debriding a bifurcation? What we did, this is just a clinical case, it's just a simple, very small access, and you see the before and after. This is really not even 1 year after treatment. You see there is an improvement of 3 millimeters of horizontal attachment gain, yet a degree 2 remained a degree 2. There is really not a change in terms of bifurcation category. And in order to do so, as I said before, we did some studies, and this study that we did was to really take all the regenerative studies with some characteristics, especially the very well designed, and we discharged all the groups on regeneration, and we kept the control to try to assess the performance of the wound. And what is very clear was that on average, what you would achieve from a horizontal standpoint when you're doing a surgery or bifurcation is approximately 1 millimeters of horizontal attachment gain, which is, to be honest with you, extremely limited. I mean, surely it's not the extent that you would expect in order to change a bifurcation class. However, the reduction of inflammation was very high, and that most probably is at the base why many molars that have been treated non-surgically, and that have been treated surgically with a conservative approach, and I would refer to you to some classical study like Hirschfield and Wasserman or Svanstrom and Benstrom, in fact, 1998, showed that the long-term survival is actually pretty good. Yet, when we go and measure the clinical extent of the healing is extremely limited. We know, and the work that I had done still from my legacy from London and from my good friend Nikos Donos and Nikos Granias, when we did some studies on the regeneration on bifurcation, that you can surely achieve from a biological standpoint a regeneration of bifurcation defects. And in the last EFP workshop, I had the privilege myself with Soren Jepsen to work mainly on the regeneration of bifurcation. And these are all these beautiful people, yet not dramatically well dressed, but lovely friends and lovely periodontists. And what we highlighted was the fact that when it comes through a technique that is called network meta-analysis, that allowed us to basically compare treatment that even were compared among themselves, that when you were using a bone graft or you were using an amelogenins or a membranes with or without, there is a surely much better effect than just opening and clean a bifurcation, especially in mandibular bifurcations, both lingual and buccal, and in maxillary buccal bifurcation. We have a problem with interproximal bifurcations because in interproximal bifurcation, and you will see it shortly in the guidelines, basically everything works from an evidence standpoint. It is difficult to recommend a specific treatment for interproximal bifurcation, and I have to say interproximal bifurcation are indeed a tough cookies. So by applying all of these, and you see here we have 2 forcation defects on the 3.6 and 3.7, and also we have an intra-bony defects on the distal root of a 3.6. So the point we open, in this case, we therefore apply, in this case, some amelogenins and some xenograft also in the distal component, intra-bony component. So we try to take advantage of this to treat the multiple defect, and this is actually 1 year after treatment, and you see that on the 3.7 is still a class 2 with 3 millimeters of attachment gain. 3.6 we move to class 2 to class 1 forcation with just 3 millimeters of horizontal attachment, and then the closure of the distal pocket of the 3.6. Now let me highlight just at the end a few points that I would like to share with you. Regeneration of any periodontal defect appears to be superior to open surgical debridement of that specific defect, to a point, to an extent, that I would have no hesitation in saying that regeneration, in case, for example, of an intra-bony defect or a forcation in the mandible, is really the elective treatment in 2020. I have no doubt in that. And even in complex defect, however, and I'm talking about the apically involved one, the suprabony component, there is always a rationale at aiming at reconstructing / regenerating. I use reconstructing because I don't really know whether I do regeneration or not over there, but surely if you don't plan to change the anatomy of the tooth, so there is no perioprosthodontic involved, I would consider that very much. And the adoption of, on one hand, flap-wise of minimal invasive concept, and on the other hand, choosing the material according to biological issue should be important in managing complex. Now, if you ever have questions that we might not cover, you're very happy to write to me on Instagram. I promise I will not reply to you within 24 hours, but eventually I will. But lastly, and this is very much the last concept that I would like to share with you, as I see now that I have still 26 seconds left, is basically that every time that you are doing a surgical treatment, please bear in mind that surgery is not the goal. Really, what you're doing here is to try to do something more, to try to change the prognosis of these teeth, to try to solve a case of a patient affected by periodontitis. And one of the tools that you have is in fact surgery. It needs to be done well, but it's just a tool. So thank you very much. It's been one of my greatest pleasure to be here to speak for my federation, on behalf of my federation. And I would like now pass over to my good friend Darko.